we think of these situations as being more lethal. But the reason why these cancer predisposition syndromes are more lethal is because they typically lead to cancer occurring earlier in life at a time in which screening for that particular malignancy is not offered. Example. Not many of you, I hope, have a lot of 20-some-odd-year-old women with breast cancer in your practice. We typically don't offer mammography or ultrasound. And yet somebody who has a BRCA1 or 2 mutation is at a considerable increased risk for developing breast cancer in their second or third decade. So what we have found out is that for the most part, tumors that occur in women with these cancer predisposition syndromes actually don't act any differently. Not better survival, not worse survival. You can't tell the difference under a microscope. Now, perhaps down the road we'll be able to use this unique genetic characterization for better treatment, etc. But for now, essentially, these tumors all act the same. What happens is if we don't know that this individual carries this bad gene, we don't know to look for it, and that's the problem. This all gets back to a fundamental concept of cancer development named after a physician by the name of Alfred Knudsen, who put his theories forward in the early 60s, and in fact it is still very much in play. Essentially, for cancer to develop, two things have to happen. There's step one, which either can happen. You go out in the sun, you get sunburned a lot as a young person, or you inherit that gene from your parents. But in order for the cancer to develop, you have to have the second step. And it has to happen, and in a particular time frame. So not everybody who inherits a BRCA mutation gets cancer, and clearly a lot of people who don't have BRCA mutations get breast and ovarian cancer. Essentially what we're talking about, although I am going to mention one new gene that may not work in the same way, is that tumor predisposition syndromes, solid tumors, and that's what we're talking about. We're not talking about leukemias and lymphomas today. Act when the genes that suppress tumor growth are mutated or are made absent. So BRCA1 and 2, when there's a mutation in that, essentially the jailers who are responsible for monitoring the jail and the prison are gone, and the inmates are running wild. That's what a tumor suppressor gene is. That is what a mutation is. Now, with leukemias and lymphomas, it's the other way around. You get a mutation that activates certain physiological, nuclear, etc. processes. And again, you see over here, this is a very brief comparison between oncogenes, which we're, for the most part, not talking about today, and tumor-suppressing genes, which is what we are. It inactivates the genes, and it primarily leads to the development of solid tumors. So why do we, in fact, want to do cancer risk assessment? Now, I want to first start off by saying what we need to do is to get rid of certain language that we use. When you talk to a woman or a man and evaluate their family history, you're not doing genetic testing. Genetic testing right now, this may change in a few years, but for right now is clearly not for everyone. What we need to do in our practice is what I call cancer risk assessment. Tell me about your family history. Tell me about your personal history. And some of the slides coming up are very busy. We're not going to go through there, but it really gives us some sort of foundation for who we should be offering genetic testing for. So we need to offer cancer risk assessment essentially universally in our own way. The American College of OBGYN supported this several years ago with a technical bulletin. It raised a lot of ire in not just the OBGYN community, but women's health community, because why are we offering genetic testing to everyone? We're not offering genetic testing to everyone. We need to find out if there is a higher likelihood that that individual in our office may have inherited a cancer predisposition gene. But for the most part, what cancer risk assessment allows us to do today, and for the foreseeable future, is in fact to determine what that woman's ultimate risk is for developing, in the case we're going to talk about today, breast and ovarian cancer. This allows us to offer cancer testing, gene testing, to appropriate people. You clearly don't want to offer genetic testing to inappropriate people because a negative result is going to be interpreted as, oh, I don't have a risk of developing, an increased risk of developing cancer, and that may not be true. I'll give you another example. If you have somebody who, if you look at their family history, is at risk for Lynch syndrome, another cancer predisposition syndrome, and you offer them a BRCA test, well, they're clearly going to be negative, and you've actually not done that woman any benefit whatsoever. You've given her false negative, in a sense, information. So we want to offer the right test to the right people. A positive status will impact the way we provide surveillance, intervention. If we do know that a family has a particular mutation, finding a negative result in an individual completely changes our approach to them. The phrase that I like to use is you take that sword of Damocles that hangs over all of our heads, and you get to push it up a little further away from that woman's head. So if she carries a mutation, you can offer risk-reducing surgery. Obviously, there's critical information for family members and for the younger women. And in fact, what we're seeing in our program, we have one of the largest ovarian cancer early detection programs in the United States. What we're seeing in our program is a lot more younger women in their 20s who've gotten tested, who are positive, and who are making coherent and rather mature decisions about reproduction in their lives. Using oral contraceptives to prevent the development of ovarian cancer, not impacting their risk for breast cancer, and then making decisions about having their children so that they can take important steps to reduce the likelihood that they're going to develop ovarian cancer. So we have lots of genetic testing in women's health. Again, we've heard a lot, especially this week, about HPV. But also gonorrhea is utilizing genetic testing in this day and age. That's more somatic. But when we're looking at germinal, which is what we're talking about, we evaluate the germline of our patients more and more. When we look for carrier screening, cystic fibrosis, Jewish genetic disorder, universal genetic screening, which is coming and is a bit scary, but it is coming, whether or not you're going to test for 100 or 200 or 500 disorders. You're going to evaluate your patients for an increasing number of conditions. My only concern as a geneticist is what are you going to tell these people about these particular disorders? And then finally, cancer genetic testing. So let's talk a little bit about cancer genetic testing. The big one is HBOC, hereditary breast and ovarian cancer syndrome, and it involves BRCA1 and 2, two distinct genes. BRCA1 is on chromosome 17, BRCA2 is on chromosome 13. They have similar, but not, or they have comparable but not similar increases in risk of breast and ovarian cancer. And for the most part, it is breast and ovarian epithelial cancer that are impacted by people who have a mutation in BRCA, but also pancreatic cancer, possibly prostate cancer in men, although that's really plus minus. Lynch syndrome, what used to be called hereditary non-polyposis colorectal cancer. Try saying that Saturday morning. Is the result of mutations in one of 6, but mostly one of 4, multiplex mismatch repair genes. Essentially genes that are involved in repairing the DNA in damaged cells. So you're saying, geez, DNA damage? All the time. Go outside, get that sunburn, DNA damage. One develops melanoma when those repair genes don't work as well anymore. So what we find with Lynch, with these particular mismatched genes, is an increased risk of colorectal cancer, endometrial cancer, and ovarian cancer. Now, there's arguments about, and there are others. There's thyroid cancer, actually melanoma as well. There's a pretty robust discussion. I don't believe that breast cancer risk is considerably increased in women with Lynch. Other people think that it is. It clearly is nowhere close to the 85 to 90% lifetime risk that we see with BRCA. But if you see somebody with Ovarian cancer in their family and breast cancer, Lynch is not the disorder that you should be screening for. On the other hand, if you have somebody with ovarian cancer and family histories of endometrial and colon cancer, clearly BRCA is not something you should be thinking about screening. The last two I'm just going to mention are far less common. Cowden syndrome, which also increases the risk for ovarian cancer as well as endometrial cancer and breast cancer, is associated with a variety of benign findings. The most frequent finding in individuals with Cowden syndrome is enlarged head circumference, primarily because of multiple hamartomas. And then finally, Li-Fraumeni syndrome with very early onset of breast cancer and other malignancies, childhood malignancies. 5-year-olds with multiple organ malignancies. It really, truly is an awful condition. A 50% risk for cancer by the age of 40, 90% risk of some cancer by the age of 60. So let's hone in on the two most common, BRCA1 and 2. They are both tumor-suppressing genes. They are inherited in a dominant fashion with very high penetrance, meaning you get the gene, you're likely going to have the phenotype or the cancer development. Again, it's found on chromosome 17, 85% lifetime risk of developing breast cancer, and you see the numbers here. But the one surprise that a lot of people have is that, you see somebody with breast cancer, let's say in their early 30s, and you say, wow, this person clearly has a genetic predisposition to cancer. And while I may not argue with that, clearly that individual has a higher likelihood. Just take a look at the yellow figure here. 10% of women with breast cancer under the age of 35 are mutation carriers. That means 90% are not. So this test is not the diagnostic panacea that so many of my colleagues feel that it is. Even in the group of women that is likely to have the highest likelihood of cancer predisposition, this test is only positive in 10%. So it's important, it's a great step forward. It clearly is not the kind of screening modality that we feel we could apply, definitely not to the general population, but even with caution to the high-risk population. And a 40 to 60% lifetime risk of developing ovarian cancer. Here we see in the red and the blue, the red is the increased risk of breast cancer, the blue is an increased risk of ovarian cancer, and in the pink and the two lighter, the light and dark pink are the baseline risk for breast and ovarian. BRCA2 is on chromosome 13. The breast cancer risk is about the same. The ovarian cancer risk is somewhat less. But the male breast cancer risk is considerably higher. We really don't see a considerable increased risk in male breast cancer with BRCA1. We see a 100-fold increase with BRCA2, and I will tell you, the one historical feature or event that invariably has me offering genetic testing is any male family member with breast cancer. I don't care if it was Uncle Joe when he was 88 years old. A man in a family history, even a third-degree relative with breast cancer, is the one definite event that's going to lead me to offer that individual, that woman in my office, BRCA1 and 2 screening. So again, as you see in the blue here, the blue line is not as pronounced as it was with BRCA1. The red line increase is about the same. Now, in certain populations, we have some benefit or some somewhat easier approach to screening. The two that are the most widely considered for founder mutation analysis are Eastern European Jews or Ashkenazi Jews. And one that we don't see too much, although I probably send in one of these a year, is in the Icelandic population. And these are the results, as we see with other either socially or geographically isolated peoples. Particular mutations increase in frequency. So amongst Eastern European Jews, there are 3 founder mutations, 2 on BRCA1, 1 on BRCA2. I tend to call this, when we order this, the kosher cocktail. It makes up about 97% of the mutations in the Eastern European Jewish population. It's a lot cheaper than sequencing, than doing the full analysis. And typically, a lot of people don't know what kind of testing they have. I then ask them how much they paid. If they paid about $300, they had the kosher cocktail. If they paid $3,000, they had sequencing. So if they know how much they paid, I can find out exactly what they had done. With Icelanders, it is one mutation, gene mutation on BRCA2 makes up 7% of all ovarian cancers in Iceland. 7%, that's an incredibly high number. For everyone else, however, sequencing is what's needed, unfortunately. And like with a lot of other genetic conditions in the United States, as our country has become less endogamous, I was going to insert a political statement here, but you know what, I'll just go forward. I think you probably all know what I'm probably going to say. But as we have become a less endogamous society, meaning we are less likely to marry within our own racial and ethnic group, these particular genes that have stayed in high frequency in certain racial and ethnic groups is going to be reduced amongst people who identify them as such, but is also going to increase in the population at large. So we see that with Jewish genetic disorders. We're going to see it also with these particular cancer predisposition genes. Ovarian cancer is also in Lynch syndrome, HNPCC. The ovarian cancer risk in Lynch is a little less than even we see in BRCA2. It's about 8 to 10% lifetime risk, but still considerably higher than the baseline risk of about 1.5%. Now, screening for Lynch is different because we don't evaluate most people with genetic testing who are at high risk. We try to evaluate tissue. So somebody has a colonoscopy, they have a dysplastic polyp removed, we want to get that tissue and look for the absence of certain proteins. Unless somebody meets the rather rigid and robust criteria of either Amsterdam meeting or the Bethesda meeting, we, for the most part, choose people to screen for Lynch mutations based on tissue, endometrial or colon for the most part, rather than their family history. Although, again, if they have a considerable family history and they meet those Amsterdam or Bethesda criteria, then we would go ahead and offer testing. I mentioned there were 6 genes. There are really 4 of any clinical relevance. As you see here, they're all distinct genes on chromosomes 2, 3, and 7. And again, they're involved in correcting the single base pair mistakes that occurred during DNA replication. And again, just getting a picture of the mismatched repair genes. The big issue with Lynch, or the most common malignancy, is colorectal cancer. There's an 80% risk of developing colorectal cancer, and the mean age of development is 44 years, so younger than we would start screening. Also, a far higher likelihood of ascending colorectal cancer, or colon cancer. Frequent synchronous and metachronous colorectal lesions, and again, 1 of 4 mutations. But what's interesting is, despite this very high likelihood of colon cancer, the majority of women with a Lynch mutation will actually present with endometrial cancer that tends to occur even earlier than colorectal cancer. So, when you do have that individual and there's some sort of family history of endometrial colon cancer, please, 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 when you do that endometrial biopsy and it comes back hyperplasia or early malignancy, think about sending that specimen for further analysis, if there is in fact a family history. Well, talked about BRCA, talked about Lynch, those are the big 2. I had to put something that we've been working on at Northwestern. And this sort of takes something from the oncogene world and brings it to the tumor suppressor world. In 2010, there was an article published that talked about a genetic marker that had been associated with non-small cell lung cancer that was evaluated in non-selected women with ovarian cancer, and in fact found that this KRAS variant was found in 25% of these cases. And as we've gone forward, we've also found that this KRAS variant was in fact associated with a higher likelihood of triple-negative breast cancer, estrogen negative, progesterone negative, HER2 negative. So, we are currently now taking a look at our large batch. Again, we have over, I think, 28,000 specimens, and looking in our various risk assessment for ovarian cancer to see whether KRAS could in fact be included in a cancer predisposition risk assessment. The study will be starting, I believe, in 2 months. We should have preliminary data, hopefully a year from now or so. We'll definitely have preliminary data within a year. But as you see here, there are also other putative genetic etiologies. I believe you heard a talk on genome-wide association studies, GWAS. Essentially what that is, that sounds very fancy and very important, but it's a fishing expedition. You take tissue or blood from a group of people who have a particular condition and see if you can find particular gene alterations that are at a higher frequency in that group. And then finally, there's also the telomere issues associated also with developmental delay, but may also be a part of cancer predisposition. Sort of forget everything that I just said, because still for us, as women's healthcare providers, family personal history is the primary method to determine risk. It is the only method by which, unless the woman comes there and says, my mother is a BRCA2 mutation carrier, or my father is a BRCA1 mutation carrier. Aside from those particular scenarios, it is history, family history, that is going to lead us to offer genetic testing to an individual. Now, again, it's important to understand the limitations of this. There are clearly limitations of screening. Not everybody with a predisposition to developing cancer has a mutation in one of the few known cancer predisposition genes. A negative result in no way guarantees protection, and a positive result in no way guarantees the development of a malignancy. But there is, in fact, changes in that. Now, you noticed this is your ophthalmology portion of the presentation. The font got small, the words got a little longer. Do not look at this, so just close your eyes for 30 seconds, take another sip of coffee. I'm not presenting this. This is what we use. This is from the NCCN guidelines. Now, in some way, shape, or form, this is what I use as a geneticist as well as an OBGYN, and in some way what you would use to determine who would get genetic testing. Please look at the syllabus online, because again, I have no desire to go through this. And again, this is readily available online from NCCN as well. Again, looking at aspects of the family history, looking at personal history, etc. And again, the easiest ones are individuals who have a family with a known BRCA mutation carrier, but again, you start seeing this. And very simply, when it comes to breast cancer, when do you start screening, not genetic testing, but screening? Just take the youngest relative, subtract 10 years, and that's when you would ostensibly start mammography, etc. MRI, we'll talk about in a moment, it's a different story. And again, here we go with all of that. When we do have an individual who may be at risk for a cancer predisposition gene, the best person to test is a person with cancer. It may be easier to test the person sitting in your office, but the best person to evaluate for that gene is an individual with a candidate malignancy. And that sometimes is a little difficult, sometimes it's impossible. Sometimes everybody with cancer in the family has died. Sometimes my patient in my office isn't talking to her sister who has ovarian cancer. Yes. There's nothing different in the cancer world than there is in the regular OBGYN world. But whenever it is possible, try your best to test somebody with cancer. Closest relative with cancer. Now, the three letters that are the bane of my professional life, and actually is going to become more common, is VUS. variant of uncertain significance. What this means is that there's an alteration in the gene sequence of a particular gene, but we don't know whether it is associated with an increased risk of cancer or it's just a polymorphism. About 12% of all women tested for BRCA mutations end up with a VUS. It needs to be discussed on the front end. Now, whether this is going to be you or the genetic center that you send the patient to for testing, doesn't matter. You need to be aware of this because if she finds out that she has a VUS, she's invariably going to come back and ask you, what do you know about this? The best thing for all of you to do is when she calls to hide under the desk. Because most geneticists don't really know too much about it, and there really is nothing to know about it. It's a change in the sequence that we don't know whether it's deleterious or not. There does not go by a week in my office that we are getting updates, in this case mostly from Myriad, but some other laboratories with other cancer predisposition gene testing, that I'm not getting an update that this particular mutate or sequence is now probably deleterious, or this sequence is now probably benign. And we go back, and again, part of our testing and counseling is that unless they have a clearly deleterious founder mutation or whatever, they are staying active in our database, and they will be contacted by us in the off chance that their mutation status changes. And yes, we even do get changes in results that were described as negative or described as deleterious. So this continues to be an ongoing process. It's a bit frustrating, but when you get these three letters, when you get that result of variant uncertain significance, the management really then depends on what is the family history that brought her there. Does she have multiple family first and second degree relatives with cancer? In that case, we typically treat that VUS as likely deleterious. However, sometimes we'll now go test other affected family members and see if they have the VUS. So you have several members with early breast and ovarian cancer, your patient has a VUS, but several of them don't have the VUS. So then it's likely not something that's deleterious. So again, a lot of this is straightforward, but some of it can be rather complicated. And again, the clinical response is based on what led us to offer her genetic testing in the first place. And testing of other family members can give us important information. Over time, the status of these sequences will in fact be better delineated. And again, this is what we typically get. We get updates whether it is now a deleterious mutation, whether it's a polymorphism or a benign. Favor deleterious, meaning there's a considerable increase in literature or information from other families that suggests that it is adverse, or favor polymorphism. So, cancer risk assessment, genetic predisposition is still primarily a counseling process. Information is taken in, evaluated by us, and then whether or not she has cancer risk testing or what. Now, a lot of times we recommend that there is no need for cancer risk testing. Patients still want to have it. We go along with it. It's like any other assessment. We, have patients who are not at increased risk for fetal abnormalities and want particular tests. So again, patients have the right and responsibility to make choices. The one thing I just want to leave with all of you is from this third bullet. If you have a hammer, everything looks like a nail. If you feel comfortable with BRCA testing, you're going to test everybody with an increased cancer risk for BRCA, and you just have to be careful. You have to look for that colon and endometrial to see if you really should be looking at Lynch. You have to look at the age. If you have a lot of adolescents and children with cancer, it's likely not BRCA. BRCA does make for a younger presentation for the disease, but not in childhood. You have to look at Li-Fraumeni. You start seeing thyroid cancers and other things like that, and she really has a big head, it's probably not BRCA either. You're not going to go back on Monday and look at everybody's head. We do have our tape measures in our office. All right. So how do we manage patients who are at increased risk? Again, you know the numbers, and if you'll pardon the expression, the numbers continue to suck. They really are awful. 250,000 or so new cases each year. About 40,000 women die each year from breast cancer. It has decreased in years past, but actually it appears to be increasing again. Ovarian cancer is about really static, 24,000 new cases each year with 15,000 deaths per annum. So again, that relationship of new cases to deaths indicates the very profound lethality with ovarian cancer. Our clinical implications for testing is to improve the ability to assess risk and therefore change surveillance. Let's start with breast cancer. We really have very few options for women at increased risk aside from surgical intervention. Increased surveillance, yes, but few conservative preventative options. We don't have pills. Yes, there's tamoxifen. Yes, there's aromatase inhibitors, but they invariably take a considerable systemic toll on that patient. Again, this is determining risk, and you start seeing where you go and put this information in to these risk models, the GAL model. These are readily available online, and I'm not going to make a recommendation of one versus the other. Every model that you use has some sort of limitation. There is no perfect model. There is no one that's better than the other, whether it's BRCA Pro or GAL or whatever. Use one, stick with it, understand its limitations, but stick with a particular model that you feel comfortable using. Again, when we take a look at people who are at increased risk, those with a 5 to 10% chance of having hereditary breast and ovarian cancer, not necessarily BRCA, there are likely other genes that we don't know about. But you see individuals with breast cancer under the age of 40, bilateral breast cancer, Jewish women under the age of 50, 2 or more close relatives. What about those with greater than a 25%? Personal history of both breast and ovarian cancer. Again, you can read it here. Have breast cancer under the age of 50 and a close relative with ovarian cancer or a male with breast cancer. So this sort of gives you a scenario of what these high-risk groups look like. Who do we start offering different evaluation for? As I said, we typically use the earliest or the youngest relative minus 10 years to start mammography, etc. Obviously, all post-pubertal girls who are coming in for an evaluation should in fact be having some sort of breast evaluation, especially after the age of 20, unless again there's this profound family history of childhood malignancies. MRI. Just briefly, MRI is the perfect combination of the good and the ugly. It's not really bad. It is clearly a far more sensitive approach to delineating early malignancies, but it's also a far less specific approach. So you're going to do more biopsies. And the reason why we don't offer this to the general population is the angst of having a breast biopsy in addition to the pain and discomfort, and then waiting the 3, 4, 5 days for the results. So we use MRI only in those people who have, as you can see, a greater than 20% lifetime risk for developing breast cancer. So the MRI and mammogram essentially every year. Those who have a moderately increased risk should not be getting MRI, and clearly those who have a lifetime risk under 15%, not for them. What about tamoxifen? Really the one chemo-preventative option that we have for breast cancer. Here we're also looking at a profound increased risk for developing breast cancer, those women with a 5-year risk of greater than 1.6%. And again, your various models will be able to give that to you. And the greatest benefit with the least side results are in premenopausal women, women without a uterus, or women with greater than a 5% 5-year risk. But unfortunately, we're left primarily with mastectomy as our most effective option. And clearly, total or simple mastectomy appears more effective than subcutaneous mastectomy. Although there are those in the breast surgery world that are great proponents of nipple-sparing procedures, and we have a lot of patients who undergo them. The plastic results are outstanding. The thing, though, to remember with surgery is we reduce risk, we don't eliminate risk. 90 to 94% reduction in risk. So women who choose this approach, whether for their breasts or their ovaries, need to understand that this is not a guarantee that they will not develop cancer. This is what I think everybody here who's done an OBGYN resident hated. Well, maybe vulvectomy. I would probably go with vulvectomy hating more than that. Yeah, vulvectomy perhaps. But this was a close second. This horrible appearance upon opening the abdomen, although for the most part it was never a surprise. The patient, presented with several-month history of bloating, increasing abdominal girth, fatigue, etc., and you'd open the abdomen and see this horrible-looking situation. Again, we're not dealing with a precursor lesion like an earlier cervical cancer or even an endometrial cancer. I'll give you a little bit of my own personal opinion about ovarian cancer, and it's really going to be the bummer of the morning for you. Baseline population risk for ovarian cancer, 1.5%, and again, you start seeing here, you have one first-degree relative, it bumps to 5%, two first degrees, 7%, hereditary ovarian cancer in the absence of breast cancer, about 40%, and then the BRCA mutations again. Risk reduction. Now here, we have great surveillance for breast cancer, mammography, MRI, ultrasound, etc. We have no effective screening. Do not get swayed that ultrasound that you're having this patient, or the CA-125, it is basically believing in a false god. Patients wrap their arms around those ultrasound results. We do as well. I do as well. The reality is that it does not work to screen even high-risk patients for ovarian cancer. What we can do for ovarian cancer is prevent it, and we can prevent it even without surgery. Birth control pills, incredibly effective. Pregnancy is effective. Breastfeeding, effective. Essentially, if you stop that woman from ovulating, you're going to markedly reduce her risk for ovarian cancer, except with one contraceptive option, Depo-Provera. The one option that is the most effective ovulation inhibitor that we have does not reduce the risk of ovarian cancer. I can't tell you why. It makes no sense, unless you think about medroxyprogesterone acetate as being a somewhat noxious molecule, which is likely you get the reduction from ovulation inhibition, and you get a positive impact, or I should say a negative impact. OCs, 60 to 80% reduction in the risk of ovarian cancer. The longer you use it, the greater the reduction. From Hannaford's most recent assessment of ovarian cancer risk, you see the numbers here. No impact on breast cancer with OCs, and these are newer pills. These are not the old levonorgestrel, norethindrones. This is norgestimate and desogestrel and drospirenone, and you see the numbers here. Even in the highest risk populations, OCs do not appear to increase the risk of breast cancer. You see from this study from Milne in 2005. No apparent increased risk of breast cancer amongst BRCA patients or those at very high risk. And again, a more recent evaluation from David Cibula from the Czech Republic, again, reconfirms this. But I used this last bullet here to segue. Tubal ligation. We have known that tubal ligation has reduced the risk of ovarian cancer for decades, and we've never known why. We talked about decreased blood flow to the ovaries because maybe there's earlier onset of menopause. We didn't know why. We now know why. And this is perhaps one of the most exciting or frightening aspects of the presentation. This is likely for many of you going to be brand new. Lots of theories, didn't understand, looked at inflammation, looked at a variety of things, couldn't figure it out. Callahan in 2007 did a study. 122 BRCA mutation positive women undergoing BSO, removal of their tubes and ovaries. In this group, asymptomatic, healthy, there were 7 malignancies. All 7 malignancies were within the tube and not the ovary. All 7 of them. And that led to an entire change in the pathology world in looking for malignancies. And what has come from this, and it's actually a previous professor of mine, Chris Crum, who when I was at Cornell was a pathologist at Columbia, and we used to actually go to Columbia for our pathology. And they have coined a new language of STICs, serous tubal intraepithelial carcinomas, and SCOUTs, secretory outgrowths. And what we now know is that in BRCA mutation carriers, perhaps up to 80%, you heard me right, 80% of malignancies start in the tube. We don't know in non-mutation carriers. We have an idea that it may be as high as 20 to 30%, though, but we don't know for sure. And this is what it looks like. This is tubal epithelium, and as you can see in the middle there is severe dysplasia, and actually it's an early malignancy. This is a STIC. So we now know why tubal ligation works. It has nothing to do with blood flow, it has nothing to do with inflammation. We were, in fact, whether we were doing it, with a laparotomy and, schlepping up a knuckle of tube and tying it off and cutting it out, cutting off the blood supply to it, we now know why tubal ligation works. And in fact, where this is going is what we've started now for women who are BRCA positive, who are young and done with childbearing. Instead of taking their ovaries out, we have started taking their tubes out to temporize that so they don't go through surgical menopause. We don't know how well this will work. We have, obviously this is done under IRB approval, but we feel very confident that we can give them effective risk reduction without the noxious aspects of surgical menopause, especially for women in their 30s. How does population-based screening work? It does, and this is the PLCO study that was published last year. As you can see here in the intervention group, there were 5.7 diagnosed per 10,000 versus 4.7 in the routine care group, but take a look at the deaths. Absolutely no difference, actually slightly higher, though it's not statistically significant. And as you can see here, this is very clear. Annual screening for ovarian cancer as performed in the PLCO trial. Now, we have a lot of issues with the way they screen, but regardless, does not reduce disease-specific mortality, but does, and I added that emphasis, increase invasive medical procedure and associated, spelled wrong, harms. So, not yet. All the things we do, we feel good about, make us feel good, but actually have absolutely no benefit whatsoever. None of these screening approaches have been shown to reduce mortality. Increased surveillance, we actually just started doing that even more so. We're taking BRCA patients and seeing them in our program 4 times a year. We were at a meeting, really a world meeting for all of these programs, and we felt that 6 months was too long of a time. We'll see if that, in fact, helps for that particular patient. Sonography. Let me be very blunt. Sonography is really good at detecting stage 3 and stage 4 cancers. We don't need anything to detect stage 3 and stage 4 cancers. We need stage 1 and stage 2. The one place that has shown some benefit for this is the University of Kentucky. It has not been reproduced. Our own study here in 2005 showed absolutely no benefit of detailed ultrasound. But the University of Kentucky has continued to demonstrate a higher likelihood of finding earlier stage malignancies, and they are the only program worldwide. I can't tell you why. Barbara Goff in University of Washington has spent her life work in looking at symptom index. We actually use Barbara's algorithm. Does it work? I don't know. The problem is that these symptoms, as we all know, are ubiquitous and common in so many women who have absolutely no ovarian cancer. Biomarkers, you all know about CA-125. You've all received the email. If my grandmother had only been offered this test by her doctor, she'd be alive today. No, she wouldn't. The issue with CA-125 is that it's elevated in so many women, from ovulation to endometriosis to PID. It is a lousy test. We use it in our program because it is a great negative predictor, but it's a lousy positive predictor. Now we look at cancer risk in HNPCC and Lynch. Colorectal and endometrial are the highest, but you see others. And this is how we screen. We can screen in Lynch. So for colon, annual colonoscopy starting in the early 20s. for endometrial and annual transvaginal or endometrial biopsy, again in mid-early 20s, annual upper GI beginning at age 30 for gastric, annual urine analysis with cytology and renal ultrasound at age 30, annual LFTs, and for skin tumors, annual dermatologic exams. So I'm going to finish up with this. I've shown you, I think, how limited our ability to intervene with patients, except for those at the highest risk. And even when we do delineate risks, we're still left somewhat wrong. Either no prevention or minimal prevention with breast, and no surveillance capabilities for ovarian. There is one thing that has changed, and changed for better, for patients better. What about the patient coming in with a pelvic mass, ovarian cyst, adnexal mass? 300,000 women in the United States each year are diagnosed with something to that. 5 to 10% of women will have some sort of surgery for an ovarian neoplasm, not malignancy necessarily, and about 15 to 20% will be malignant. We know the workup. It's found on a pelvic exam, you get an ultrasound, do a CA-125, etc. The ACOG and SGO guidelines, self-admitted from oncologists, are lousy. They really are lousy. They clearly have too many women with cancer falling within the cracks in these two particular guidelines. So can we do better? Well, not only can we do better, we must do better. Because it turns out that women with ovarian cancer, if they are operated on by a skilled surgeon, an experienced surgeon with cancer surgery at a cancer center, their likelihood of survival is markedly increased and their longevity is markedly increased. So we find somebody with an adnexal mass. Do we have a better way of triaging these patients? And the answer is yes. Ultrasound by itself doesn't work. CA-125 by itself doesn't work. But when you start putting these things together, you start getting better information. Jacobs in the UK put together something called ROMI, Risk of Malignancy Index, giving scores to ultrasound, menopausal status, and finding an improvement over the individual criteria. Most recently, we heard of OVA1, perhaps not in the context that it should have been, that it was now the ovarian cancer screen, which it's not, but OVA1 are 5 biomarkers that, in fact, considerably improve the likelihood that we're going to be able to determine whether that adnexal mass is malignant or not. But the most recent one, and the one I put in there because I've been involved with this in its development, is something called ROMA, Risk of Ovarian Malignancy Algorithm, and it contains CA-125, a new biomarker called HE4, and menopausal status. You can go online and put these numbers in, and it spits out what I call a fortune cookie answer, meaning high risk, low risk. When you take a look at ROMA, which was really developed by Richard Moore and at Hershey and at other places, as you see here, you start getting considerably improved sensitivities and specificities for determining the malignancy of a particular adnexal mass. And as we see here in this comparison between ROMA and ROMI, you see a considerably improved sensitivity detection rate with comparable specificities. And when we compare OVA1 to ROMA, you see the sensitivity is about the same, but the specificity in this comparative study was markedly improved with ROMA versus ROMI. The other issue is that it's considerably cheaper than the OVA1. Now, I will tell you this, I don't care what you use. I don't care if you use ROMI, OVA1, or ROMA. We use ROMA, again, for cost and for ease of use, but I don't care